Okay.
This meeting is being recorded.
Okay. Okay, let me find where I'm going.
Look at those angels.
There I am. Okay. We're going to start. The first couple of chapters from last week are about education, using health education in the community, and how to do a community assessment. That's chapter 12. So, what kinds of things? Why would we be using health education in the community? What does the community need? What do you think?
Resources for like diseases like communicable diseases.
Mm-hmm. Yep. Most of what you're doing in community nursing is education, right? Public health nursing, a lot of public health nursing is education, and most of what community nursing does is education. So, using health education in the community is happening all the time. Okay, and this is your outline. So here's your summary. We'll go through the education process, and then we'll go through group tools in health education, and then, follow these objectives. You should be able to explain these 6 things after we cover this chapter. Okay, so a couple of things. Healthy people comes up real quick in chapter 11, page 183. Okay, and so their examples in this chapter are related to health education. Okay, so I'm not going to read through them. You can read through them, but they're all related to health education. Well, I'll read one of them just to give you an idea. Increase the proportion of college and university students who receive information from their institution with regards to health risk behaviors. Okay. So those are there 4. We need to know those. Okay. Why do I feel like I'm in a tunnel? Does somebody need to be muted? Maybe that's it. Or is that me? Oh, Margarita, I'm going to mute you. There we go. Okay. So, here's why health education in the community is important, right? When we're designing, and think ADPI here, when we're designing, implementing, and evaluating health education activities, right, we need to understand what the primary health problems are in the community, right? We need to know what education principles that we're going to use that relate to both teaching and learning, right? And so the goal of educational programs in the community is we have to teach people what they think they want to learn in ways that facilitate their learning. Okay, we want the community participating in the development of education programs, right? Hopefully they'll buy into it if they're part of the planning process, right? We may be planning education to meet a specific healthcare need. We may be doing classes in the schools. Let's say the schools teaching about asthma, teaching about allergies, maybe working with the elderly with regards to diabetic management, right? So lots of different ways to educate the community. Okay, it's typically the education is about health promotion and illness prevention. Okay. So do we understand the difference between education and learning? There is a difference, right? Education is gaining the knowledge, right? Gaining the knowledge, attitudes, skills about a specific topic. Learning is putting that knowledge into practice. Okay. Oops. Okay, so we need to know the difference between education and learning. Okay. And then the nature of learning. There's 3 ways to look at it, right? Cognitive. These are the ways we learn. Some of us are cognitive learners. which is thinking. Some of us are affective learners, which is feeling. And some of us are psychomotor, which is hands-on, acting. Right? Understanding all three of these domains is crucial in providing accurate health education. Okay, and a little bit more specific with cognitive. So cognitive, we just said, is thinking. So it includes memory, recognition, understanding, reasoning, application, problem solving. Okay. Then affective includes changes in attitudes and the development of values. This can be a very difficult domain because a lot of times it's really difficult to change deeply rooted attitudes and beliefs and values. Anybody know a person like that? I do. Where people are just set in their ways and they're not gonna move. Okay, then psychomotor is the hands-on teaching, having clients perform skills, teaching them, maybe teaching them how to bathe their infants, changing dressings, giving injections. Okay, so those are the three domains of learning. Okay. Your QSIN box, your competency in this chapter is client-centered care. This is a good one to have a look at this. Okay, so what does the educational process look like? Think of ADPI here. Okay, educational process builds on an understanding of education, learning, and how people learn. Okay, and there's 5 steps. We're going to go through those 5. First is a needs assessment. Obviously, in order to perform any kind of education, there needs to be a needs assessment. Otherwise, to select a topic. Box 11.1 gives you the 5 steps of a needs assessment, or the steps of a needs assessment. What do people want to know? How do we collect data? How do we analyze it? Okay. Second is establishing goals and objectives. Right? We have to talk to the potential learners. What are their needs? How develop goals and objectives with them. Okay. Then we have to select our appropriate education methods. Okay. Here's a good teaching mnemonic, box 11.2. Okay, how to effectively teach clients. Tune in, edit, act, clarify, honor. Okay, when we're choosing different educational methods, there's so many things we have to take into consideration: age, gender, culture, ethnicity, developmental disabilities, special learning needs, size of group, right? What if you have a group that has visual impairment? What if you have a group that is hearing impaired? What if you have a group of kids that their attention span is short? What if you have a group of people that are maybe hard to motivate? Okay, lots of different needs, Okay, have a look at your levels of prevention box. It's related to this, it's related to education. Okay, and here is an example how they really specify how education is in every single level here. Remember, I told you early on, don't get caught up in education just being a primary prevention. Here's an excellent example of using education at all 3 levels. Primary, we're educating at health fairs with regards to preventative things, immunizations, older adults, immunizations for everybody, actually. Okay, we're trying to be proactive. Secondary, we're educating at health fairs regarding an early diagnosis and treatment save diabetes, right? With the goal of shortening the disease duration and severity. Tertiary, we're still educating, but we're educating in a rehab center or an adult daycare center for a group of people who've had a stroke. Everybody understand that? Skills, another factor, another thing to consider is the skills of the educator. Hey, are you knowledgeable about the subject? Can you gain their attention? Can you answer their questions adequately? Can you present the material clearly? Okay. And then motivational interviewing is the last in the process. Okay. What is motivational? Where motivational interviewing is doing an assessment of what the specific need is. Right. Health education goal is to engage the clients in wanting to learn ways in which they can change their behavior. Okay. Oops, sorry. Okay, so how do we develop effective healthcare programs? Okay. First of all, this how-to box is very helpful on page 189, how to use plain language with health education. Okay, and there's 3 sections here. How to organize your audience, how to choose your words carefully, and how to make information easy to find. What are some things that we need to consider, population considerations based on age and cultural and ethnic backgrounds? Okay. So what this means is all the different generations that we're teaching. So let's say we're teaching Generation X or baby boomers, or what do they call them? The digital group. Everybody requires different ways of learning or different ways of having things taught to them. Okay. And here's a couple of examples they give you with younger children. Use more concrete examples and word choices. Okay, this whole section is about teaching kids and how to develop your teaching strategies for different groups. Okay. And what are some educator related barriers for us that are teaching? Before I keep going, I have a question. Has anybody ever been part of a group that has either organized a teaching class or seminar, or an either yes or no? And then I'm sure the answer to question 2 is yes, is have you ever attended an educational session, whether it's a new job for orientation or training for a new job? I mean, this is what this whole chapter is about, whether you're an attendee or whether you're the actual teacher. Okay, so what are some education related barriers? Does the speaker teacher have a fear of public speaking? Maybe lack of credibility with a topic, limited professional experience, and so on. Lots of different barriers with the educator. And then what are some learner related barriers? Okay, we know that this is important. 2 of the most important learner related barriers are low literacy and lack of motivation. Okay. Nurses often deal with individuals and populations who are illiterate or have low literacy levels. And that can be difficult to identify and assess, right? There's 2 education models that we can use to teach. Okay, one is called the health belief model. These are health promotion teaching models. Okay, and the health belief model is typically used when you think that motivation is going to be an issue. Okay, and it has 6 components that attempt to answer the question of what motivates an individual to do something. And if you want to read more about that, it's in this paragraph right here, page 193. Okay, an example of that would be, let's say somebody, maybe a new diabetic, let's say a teenager. This happened to me numerous times, a teenager that's diagnosed with diabetes who doesn't really, yeah, it's no big deal. They play sports and no big deal, and they don't have, it'll be fine. You know, I don't really need to check my blood sugar all the time. And so we would need to try and use this model using these 6 components to help them understand that no, we do need to take this seriously. Okay, we can't blow this off. Okay. And then we have, it's called the trans-theoretical model. And another word for that is the PAPM, precaution adoption process model. Okay, and this model is used for health promotion. Okay, and that has 6 stages as well. Okay, so I just need you to know that those are 2 different models that we use to teach or develop education programs to a specific audience. Okay. I think that, okay. So the one thing I want to mention about group role behavior, you've all just completed a second group project or almost done. Okay. There's lots of group dynamics when we're doing group role behavior. Okay. Here is a list, a common list of different roles that might be assigned in a group project. Okay, you have your follower, your gatekeeper, your leader, your peacemaker, and your task specialist. I don't know what roles you guys have played in your groups. I don't know if you've had other group projects to do, but you could all probably find, you know, one of these 5 roles that you would like to do in a group. For me, I like to be the leader. Shocker. Yeah, I like to be the leader. I like to be guiding and directing the group and keeping everybody on track, and just like to kind of run things. So, but you know, others may not want to be a leader, just be a follower, just participate and just go with the flow. Okay. So that's just box 11.5 is examples of just different group roles you may have. Okay. And I like this. This is nothing we need to memorize or anything, but box 11.6, what are some core competencies for communication skills as educators? And this actually can go a long way, not just education, just in general. Right? You should be able to communicate, and just think of nursing as a whole, right? Communicate effectively, both in writing and orally, including via email. You're going to be communicating with team members. You're going to be communicating with doctors. You're going to be communicating with other medical teammates. You need to be able to communicate effectively, both writing and orally, right? You need to seek out input from others, right? Be an advocate for public health programs. You will eventually lead and participate in groups to address specific issues. Okay. There's a few more of them. And attitudes. You need to be able to listen to people in an unbiased manner and certainly respect the points of view of others, right? And promote the expression of diverse opinions and perspectives. So I know this is in the communication skills for educators, but I would argue that these two pieces of information, communication skills and attitudes, carry much further than just education. Okay, so any questions about using health education for groups in the community? I'd like to jump to chapter 12. Oh, sorry. Which is community assessment. We've talked about doing so you guys are used to doing individual assessments in the hospital, right? So this is, and we've talked about doing individual assessments in the community. We've talked about doing family assessments, environmental assessments. What else? Now we're going to talk about doing a community assessment. Okay, how do you do an assessment for the whole community? Okay. So in this chapter, our client is the community. Sorry, I muted myself for a minute. Sorry about that. So in this chapter, we're going to look at our client is the whole community. In previous chapters, we've looked at our client is an individual, or our client is a family, or a client is an aggregate of the population. Now we're just going to look at the community as a whole. Okay. So again, read through your objectives. That's what you need to have a solid understanding of. Okay, and this is what the information I'm trying to pull out for you are the chapters to meet the objectives. Okay. Okay, so again, with your ADPI, the nursing process from assessment all the way through evaluation is also used to promote community health, right? And so this begins, so assessment, your A in ADPI is assessment. And in this chapter, we're talking about a community assessment. And community assessment is actually one of the 3 core functions of public health, which involves getting to know your community. How does that look? Okay, there's a definition of community. You can have a look at that. Okay. So first and foremost, what are the 3 dimensions of community we look at? We can look at, we're on, let's see, table 12.1. We will look at community as a place, as a people, and thirdly, as a function. Okay. And this is a nice chart on what is the place measure? Okay. What are the geopolitical boundaries? Is there a local name or nickname for that place? How big is it? What kind of transportation does it have? Okay. And over here on this side, it's examples of where you might get data, because remember, we're doing an assessment. Where would you get that data? Okay. You may be going to the Chamber of Commerce to get some of that information. Library, local housing office, local newspaper. And then how do we measure people, population?
Professor Marvel.
Yes. Yes.
So for like places that I'm just trying to like define it, is it kind of like just like places as far as it goes, like a city?
Yeah. So we're looking at community as a place, right? The actual place of the community. What are the boundaries? How many square miles? What does transportation look like? What does the community look like? Okay. Does it have rivers, highways, railroads, sidewalks? What's the physical environment? Okay, so community as a place. And then when we look at it as a people, we're looking about the population. Okay, what's the number? How many people? What's the density? What's the demographics of the population? Is it a young community? Is it an older community? Does the community have socioeconomic factors? What's the racial distribution? Is it urban? Is it rural? Okay. How is the population? How is it made up? Are there book clubs, service clubs, friendship networks, right? And what might we get some of that information? Okay. Again, churches, senior centers, civic groups, newspaper, tourist bureau, chamber of commerce. Okay. Then the third way we look at a community, third dimension we look at a community is the function. What is the function of the community? Is it a college town? Is it a industrial town? Is it an agricultural town? Is it a rural town? Is it an urban community, suburban community? Okay, what's the function of it? What do they produce? If they produce anything, how do they distribute anything? You know, what are their goods and services? Okay, so what is the function of the community? So there you might look at turning to business and labor people for information, local library, police station. Okay, so those are the three dimensions of community assessment. Your people, place, and function. Okay. This is important too here, page 205. Identify community systems. Okay, there's 9 listed here. The following list is system categories found within in a community. So that's the fancy way of saying every community is made up of at least these 9 things. It looks different in every community depending on what the priorities are. But if you get a question that says, which of the following are common categories found with each community, your correct answers are any of these 9. Every community has politics and government. Every community has a safety and transportation system. Every community has education. Obviously, they have a physical environment and on. Okay. So these are there's more characteristics, categories. There are more categories obviously found in every community, but these are the 9 that are addressed in this book. Okay. So please know those. Okay. So goals and means of community-oriented practice. Do you remember what community-oriented is versus community-based? Remember, community-oriented is the big picture, right? The nurse and the community look to make changes together, right? They're assessing, where community-based is you're already working in the community with the ill population. Do you remember that? Okay, so community oriented, you're looking at health promotion, disease management. Okay. So one of the things we look at is status, right? Community health in terms of the status or the outcome is the most well-known and accepted approach, right? It involves 3 things. Okay, it involves looking at the biological makeup, the emotional, and the social. Okay. And biological, just as an example, we'll look at morbidity and mortality, right? Life expectancy. And then risk factors. Oops. And then we look at the community, the structure. What's the structure of the community? So there's 3 different ones. There's the status, The structure. Structure refers to resources, services and resources offered by the community. Okay. And then what's the process? The view of the community health is a process of how does the community function? That's what that means. Community competence, where parts of the community, organizations, groups are able to collaborate effectively. Okay, so is it an effectively functioning community, or is it very chopped up and parts of the community are healthy, other parts are not? Is it a community that is, you know, ridden with violence or whatever? So process means how effectively is the community functioning. Okay, and then here's a summary of the three of them. Okay, so these are the concept of community health specified with regards to status, structure, and process. So again, status is all your vital statistics, incidents and prevalence of what's causing mortality, morbidity, health risk profiles, functional ability levels. And again, here's where you get them, or you can gather some of this data. So remember, you're the community nurse doing a community assessment. Okay. What's the structure? What's the community made up of? Hospitals, nursing homes, schools, health departments. Okay. And again, over here, some places to get that information. And then the process. How does the community function? Right? Awareness of self and others, effective communication, conflict containment, participation, relationships. Okay. Okay. So the status, structure, and process define community health. Three important parts to define community health. Okay. And then Healthy People 2020 is presented here on page 209, right? And it talks about Healthy People 2020 provides a foundation for a national health promotion and disease prevention strategy built on 4 goals. And I can tell you this right here was I just sent you a Kahoots a couple of days ago. Maybe, was it today or yesterday? I sent you a Healthy People 2020 Kahoots, which is kind of a summary of all the Healthy People 2020 throughout the whole book. And this is one of the questions in there, right? It provides a foundation for national health and disease prevention built on 4 goals. And here's the 4 goals. Okay, so please know that. That's important to know. And then the other thing I want to talk about is the difference. In order for communities to function effectively, you have to have community partnerships. Okay. Community partnerships are broken down into active and passive. Okay. And a good example of an active partnership is things, let's say a business in the community actively provides healthy after school meals for the schools. That's active. In there, doing it, it's getting done on a daily basis. Okay. Where passive partnerships are all those people that sit on boards and task forces that are always planning and assessing and implementing changes for the community. Maybe the group that's planning the new rec center, or the group that's planning the new neighborhood mall. Okay, that's passive participation. Okay, so you understand the difference? Or active, it's happening real time, in effect. Okay. Whoops. Okay. Let's go through an overview of the process from assessment to an evaluation. So this is your whole ad pie of doing a community assessment. Okay. First is your assessing. Okay. Community assessment is one of the three core functions of public health nursing, PHN. Right? It's actually the process of thinking critically about the community. Okay, what are the geographic boundaries? Who are the members? What characteristics do they have in common? Okay, and I've highlighted a little bit about what the assessment does. Helps a nurse in the community to understand individual, family, and group problems. What are the community strengths and resources? Okay. Next is data collection and interpretation. Okay, and there's two things we need to know here. Okay, well, data collection is simply to gather information about the community. Okay, but there's a difference. Okay, there's data gathering and there's data generation. Let's talk about data gathering first. We need to know the difference. So data gathering, you're gathering together, I call it existing readily available data. So you're just gathering up what we already have. Right? And that's usually maybe the demographics. So you can go to those sites or those areas that were in the above boxes of where to potentially go and get the information. Right? The age of the residents, the gender, the socioeconomic characteristics. You can go and gather that information up from sources. Where data generation is, we don't have the data readily available. Okay, so we're going to have to get it through community interactions, talking with people, talking with individuals, families, groups. Okay, and the way we get this information, here's some examples. We may be looking for what their values and beliefs are, what their goals and perceived needs of the community are, what the norms are. Okay, what's their leadership structure? Okay, so that's data generation. You're going to have to get out and about and talk to people to get that kind of data. Okay. Okay, here's a couple of data collection methods. We all know what an interview is, observation. What's a windshield survey?
Driving through your community and observing the environment itself and collecting data based off of that information you observe.
Okay, and what are you observing for?
Just depends. It can be
How many schools there are, how many hospitals there are people out walking around, are people not walking around, are kids riding their bikes, are people hanging on corners, right? You're getting a general sense. Is the community clean? Is it dirty? Does it seem to be bustling or does it seem to be super quiet? Okay, that's how you do your windshield survey. You're observing right here. Table 12.3 is a good summary of windshield survey guidelines. So please know what a windshield survey is and be able to answer a question about a windshield survey and what it is. Okay, and here's some things you can see in a windshield survey. Boundaries of the community, housing, open spaces, common areas, transportation, social service centers, stores. Are people out walking their dogs? Okay. And then in the community, remember you're the new community nurse doing an assessment, that you're going to have to find key people in the community to speak with, right? You can't do this all by yourself, right? You're probably going to want to talk to law enforcement if there's an issue of, I don't know, say gang violence or crime, right? You probably want to talk to the education people, parent teacher, PTA presidents, maybe talk to the mayor or local politicians, county health department. This is what you're kind of being asked to do with your vulnerable populations paper. Okay. And then be careful. How do we determine the usefulness of websites we might use to gather our information? Okay, this how-to box on page 214 is a good box. How credible is the information? How recent is it? When was it last updated? Okay. Are there obvious biases in the reporting? Okay. And then one of the other issues with assessment is one of the most important things is trying to gain entry or acceptance into the communities. And that we've heard this before, but that comes with building trust. Okay. If you are this new person coming in and snooping around and asking all these questions, that's probably not going to fly. Okay. You need to build rapport. You need to build a relationship with the community in which you're assessing. Okay. And this is a nice little example of things you can do, right? Page 214, how to gain acceptance. Okay. And then the most important thing to remember with goals and objectives is once you've identified your problems, goals and objectives are developed, but they need to be developed with the people who have an interest in seeing these problems solved. Okay. It has to be a group effort. By not only you may be kind of the group leader of it, but you have to pull in people. And it requires a great deal of collaboration, or a great deal of patience and listening and good communication skills, but you need to have everybody involved. You want them to have a vested interest in whatever the goal is for the community. Okay. Okay. So that's it for community assessment. You guys have a good understanding of community assessment. Yeah, community assessment's a big one. It's a big job. I always say, pretend you're the new nurse who's moving out of state to this new community. You were just hired to be the community nurse of this community, and they haven't had a community assessment done in several years, and they want you to do an assessment. Where do you start? Well, we just went through it. Okay. All the different ways you put together a community assessment, all the resources, all the tools that you have. So let's shift gears here and talk about economic influences in healthcare. Okay. Okay, we know that poverty is directly related to poorer health outcomes. Okay, we've talked about this over and over again. We know that poorer health outcomes lead to reduced educational outcomes for kids, poor nutrition, low productivity in the workforce, unstable economic growth in a population, community, or our country. Okay. What factors contribute to that? Okay. Well, first, let me give you a couple of stats. 97% of our healthcare dollars are spent on individual care. Okay, only 3% is spent on population level healthcare, meaning so little of our healthcare dollars is spent on prevention, right? Most of it has spent on individual health issues. Okay, when somebody gets sick, that's what it's spent on. Okay, the United States spends more money on healthcare than any other country. Okay, we know that the current healthcare system here is at a point where it's at a point which it's not affordable. Right? We as community nurses need to be knowledgeable about healthcare economics, right? That's important to our role because we are often, as in the public health sector, we're often the ones that are allocating the resources. The state will give public health departments a certain amount of funds. We're usually the ones doing the community assessment, thinking, well, we have an immunization problem. Do we allocate resources to immunization clinics? We have a problem with, whatever the problem is. Typically, it's the community health nurses that are going to be allocating resources to whatever the community needs are. Okay, so you have to be mindful of what's going on. Okay. And I thought this was interesting. Public health system has previously, for years and years and decades, was only considered to be involving the government public health agencies, such as health departments. But now, public health system is branched out to so many different areas, right? Schools, industry, media, environmental protection agencies, voluntary organizations. It's so much more now. Public health nursing or public health, period. Okay, what are a couple of big factors that affect the resource allocation? Okay, the number one is the uninsured. Uninsured plays a huge part in the cost of healthcare. Okay, and then the second factor is the poor. Okay, we know that socioeconomic status is inversely related to mortality and morbidity for almost every single disease. Poor Americans with an income below the poverty level have a mortality rate of nearly 3 times of middle income Americans. That's crazy. And that's even after they've accounted for age and sex, race, education, risky behaviors. Okay, access is also a huge issue. Okay, if you don't have insurance, your access is limited. I mean, sure, you might qualify for Medicaid. What if you don't qualify for Medicaid? Okay, so access can be a huge issue. And then rationing of healthcare in any form implies that you have reduced access to care and probably not the highest quality of care as well. So those are four pretty big issues. And here's your Healthy People 2020 box that their objectives related to access. And they're simple: increase the proportion of people with health insurance, and then reduce the proportion of people who experience difficulties and delays or obtaining medical, dental, or prescription. And then here's our levels of prevention. With regards to economic prevention strategies. So primary, work with legislators and insurance companies to provide coverage for health promotion to reduce the risk of diseases. That's being proactive, trying to be preventative. Right? Secondary, encourage clients who are pregnant to participate in prenatal care, participate in the WIC program, right? To increase the number of healthy babies, reduce the costs related to preterm care, right? That's early identification of risk and early intervention. Get them involved with the prenatal programs available to them, right? And then tertiary, participate in home visits to mothers who are at risk for neglecting babies to reduce the costs related to abuse. So they're already a new mom, right? And we're going to be doing home visits to those new moms and doing an assessment to try and reduce costs related to abuse. Do you guys understand why that's primary, secondary, and tertiary? Okay. And then, so these are, let's see, this is the makeup context, the makeup of the US healthcare system. Okay. It goes through five, you don't need to know what all these stages are, but just knowing that what the US healthcare system is a diverse collection of industries involved directly or indirectly in providing healthcare. Okay, the major players are obviously health professionals who provide the services like us, pharmacy, equipment, insurers, managed care organizations. Okay, so it's made up of a lot of different entities. Okay, and then it goes through the phases. And this is all a historical perspective. You don't need to worry about this. So I'm going to skip through this. But it is cool to read about if you're history right here. Okay, it starts in the 1800s. Okay. I want to talk about the payment system. That's what I'm trying to get to. Okay, one of the things, a couple of factors, big factors influencing healthcare cost. One is demographics. We've talked about this before. One of the major demographic changes underway in this country is the aging population. Right? Why is that?
Baby boomers are getting old.
Mm-hmm.
They're getting older.
Mm-hmm. Mm-hmm. Like me. Mm-hmm.
They need more health care.
Mm-hmm.
They're going to need in the future. So,
Yep. And what are they going to have? Multiple chronic conditions. Okay. The aging population has multiple chronic conditions. It's a big chunk of our healthcare. Taking care of people with chronic conditions. Okay. Chronic conditions, chronic illnesses is a new factor affecting healthcare spending, right? They say that chronic disease accounted for approximately 70% of the deaths, and we're going back to 2010. Okay, in the last part of this chapter, I want to focus on financing. There's four areas of how we finance healthcare. Okay, one is public support. Those are your government programs. That's your Medicaid and your Medicare. Okay, there's a nice little table 8.3 gives you the differences of Medicare and Medicaid. I know you've seen it in other chapters. This is a pretty succinct chart. Okay, and I highlighted the specific things to know. Recipients. Who takes Medicare? Who takes Medicaid? Medicare is a federal program, Medicaid is state. And then what services do they cover? Okay. And then this goes through and talks about Medicare and Medicaid. Okay, so we're still in public support. Okay. And then we have public health financing. So this is when the government they give their money out to the local, state and local. Well, they give it to the state and the states give it to the local health departments. Okay, and they use it in ways that meet the needs of their community. Okay. WIC programs, immunization clinics, well baby checks, those kinds of things. Okay, whatever they need. Okay, then we have the third category is called other public support. And this is your Tricare. So this Tricare is your health for military and their dependents. That's Tricare. And then also the VA is in this as well. Okay. Then we have the fourth, which is private. Okay, and private is your employers have health insurance for you. You have health insurance through your employer, or you're purchasing it out on the open market. Okay, and the rest of this chapter goes through all the different kinds of private support. We don't need to go through all that. I just want you to know the 4 categories of how healthcare is paid for. Make sense? So the rest of it is managed care and PPOs and HMOs and medical savings accounts. Okay. So that's our economic, our economic overview of how healthcare is managed. Why is this? There we go. Okay. Any questions on that? All right, let's get into a couple of, let's get into, this is kind of a hard chapter, violence and human abuse. Okay, so we're going to cover the last 3 chapters for this week, which is violence and human abuse, infectious disease prevention and control, and then our common communicable diseases, the HIV, the hepatitis, the TB, and the STDs. Let's start with violence and human abuse. As a nurse working in wherever you're going to be working, it doesn't matter. You are going to be taking care of patients that are victims of violence. You're going to be taking care of perpetrators of violence. You're going to be taking care of, you're not going to escape the consequences of violence in the people that you're taking care of and working with. Okay. So the first part of this chapter is what are the factors for, read your objectives. Okay. The first part of this is, well, healthy people comes up quick. 434, objectives for reducing violence. There's their objectives for reducing violence. Okay, so please know these. 7 of them. Okay. And the first part of this are, what are the first part of this chapter is, what are the factors that influence violence? Okay, the first social factor is work. When we think of work, we think of workplace violence. Okay, what causes workplace violence? Right? Maybe people are frustrated with their job. They don't get the promotion. They don't get the raise. They don't They have issues with their coworkers. I mean, how many times do we see it on the news all the time? Workplace violence. Okay, so work is a factor. Okay, that affects violence. Schools, education. Right? We have bullying, we have harassing. Right? We have school shootings, school stabbings. Right? Bullying's a big one. Okay. How does the media contribute to violence? Well, I guess maybe look at some of the video games that kids get to play and look at some of the TV programs kids get to watch. And yeah, I'm 60 years old. I'm old school. I can't believe some of the stuff on TV, some of the stuff these kids can watch. You know, what is it? My granddaughter was watching TikTok and the stuff. TikTok. I mean, oof. Anyway, media plays a very important role in the way we perceive violence. Okay. Like I said, video games, television shows, music, lyrics, right? All plays an important part. And then religion, right? I mean, we've seen the violence against religious places of practice. Okay. And then your population in general, whatever the community's makeup is. If the community is a very poor community and people live in very crowded conditions, you know, maybe tension, violence is greater, right? High density communities can negatively influence violence, right? Crime rate, gang activity. Right? You know, what if your makeup in the community next to last one is community facilities? What if I mean what if you're a community that has rec centers and pools and playgrounds for the kids and movie theaters and all that? Keep people busy doing things. But what if you're a poorer community that doesn't have any of that? What are these kids going to do? What are people going to do? Okay. So all those are factors contributing to violence. Okay. Social factors. And then we look at violence against either individuals or oneself. We look at homicide. We all know what homicide is. We look at assault. And then we look at sexual violence and rape. Okay. Those are all against others. And then the last is with yourself, against yourself, and that's suicide. Okay. And we all know these numbers are increasing rapidly, actually, especially over the last couple of years. Okay. And then as a nurse working in the community, you've got to be aware of what is the makeup of family violence and abuse? How do you recognize it? Can you recognize sexual abuse, emotional abuse, physical, financial? Right? Are you able to recognize a kid who's been abused or a spouse who's been abused? Typically, they end up in your emergency room. Okay, we're in a key position to recognize, assess, and recognize abuse. We all know what the mandatory reporting means, right? What does mandatory reporting mean?
Or to like child services. if you suspect or have evidence of abuse.
Mhm. And we are mandated reporters for any kind of abuse, right? Child abuse, elder abuse. And is it just at work if you observe something? Or is it everywhere? The answer is everywhere. We are mandated reporters. Doesn't matter if you're standing in line at the grocery store. Okay? And you hear something or see something, you're a mandated reporter. You must report any kind of suspected abuse. Okay? So nurses, we need to be able to understand what factors may be contributing to it. We need to be able to identify, they call it abuse-prone families. I had to do that all the time in the schools. Okay? There were certain criteria that need to be met, but we did that, you know, with families of kids that were coming in with bruises and injuries. Okay, how do you talk with those families? How do you talk with those kids? We also need to have an understanding of what are abusive patterns. Okay, just have to do with their upbringing, their living conditions, increased stress, if they lost a job. Okay, types of family violence, physical abuse, sexual abuse, neglect, intimate partner violence. And this is a very interesting box 25.1. Okay, abuse is about power and control. I don't need you to memorize this entire box, but I'd like for you to know the headings here: abuse, isolation, threats, intimidation. I didn't quite get through this with my earlier group. Using the kids. Being cruel, withholding support, sexual abuse. Okay. Child abuse, you have to be able to recognize it. Okay. Right. Many kids are exposed to violence not only as victims, but also as witnesses. Right. Kids witness domestic violence. Kids that do witness domestic violence may experience PTSD and maybe themselves exhibit aggressive behavior. Right? Kids living in homes where violence takes place between their parents are more likely to be abused themselves. Right? Maybe substance abuse issues, social support issues, resource issues, who knows? And then there's a couple of how-to boxes that are real helpful in this chapter. This first one is box 25.2. It is determining risk factors of child abuse. Okay, these all will contribute. Are the parents unemployed? Can they care for the child? Do they have a support network? Do any of the parents have a history of child abuse? Is there any intimate partner violence going on? Is there a lack of education about child development and they just don't know? Okay, any substance abuse going on? Are the parents overly critical of the child? Gosh, I had this example of this family that, oh my gosh, elementary school, but every time we had a meeting, the student was on an IEP, this little girl, she was on IEP and she was doing great. I mean, she was just meeting all her goals of her individual education plan. She was a special ed student. And every time we had a meeting with the parents and, the whole group met annually, would have a meeting and just talk about how great she was doing. And the mother would say, yes, but she has this problem. Yes, but she has this problem. Every time we solved problems and she met her goals, it was never good enough. It would create a whole new set of problems mom would bring in a whole new set of problems that we had to deal with. So it was just really, really sad. And that was parents overly critical of the child. I had a horrible experience with that. And this went on for all through elementary school. It's really sad. How to identify potentially abusive parents. Okay. And then how to recognize actual or potential child abuse. Injuries, burns, fractures, malnourishment, dehydration. Okay. And then this is just a list of what abuse can look like. We all know these. Physical abuse, how it may present. Emotional abuse, how it may present. Financial abuse. So, yeah. And then elder abuse. That's the last part of this chapter. We have to be familiar with elder abuse, right? It's a form of family violence, right? And like child abuse, spouse abuse, most cases of elder abuse go unreported because the elder person is afraid to tell police, friends, or family about the violence. Why? Because maybe they'll be shut off from care. Maybe they'll be isolated. Maybe they'll be further punished, right? Right? Emotional abuse of elders, demeaning them, affecting their self-esteem, name calling, scaring them, embarrassing them. It's really sad. But we have to be prepared to recognize it. Most common form of psychological abuse is rejection or simply ignoring older adults, indicating that they're worthless and useless. Okay, and here's a great box of how to identify potential or actual older adult abuse. Okay, here's the things you need to be alert with. Okay, and that's all I wanted to cover in this chapter. Oh, actually, nope, there's one more thing. So primary prevention, what do? Primary prevention begins with community approach, right? This is nursing interventions. This is to try and decrease violence. Okay. So we are trying to participate in primary prevention, which pulls in everybody that we need to in the community. Okay. It pulls in criminal justice, pulls in education, social services, community advocacy, and public health, all to try and prevent violence. Okay, so here are 6 strategies that communities have used. Sure, there's many more, but these are the 6 that we identify. And these are excellent. So be familiar with these because these are important primary prevention measures. Okay, and they're done as a group effort with the whole community, right? Develop a curriculum that teaches children and youth how to cope with anger and stress and frustration, right? Teaches them good communication and mediation skills. And then family programs that teach parents how to deal with their children more effectively. preschool programs that develop intellectual and social skills. Okay. And a few more of those. Okay. So that's violence and human abuse. Do you have any questions about that chapter? And in the community, you are going to see that working out in the community. Okay, infectious disease and prevention. Infectious disease prevention and control. Okay. A few things we need to know in here. Okay. Familiarize yourself with the objectives. Okay. Okay, so first that comes up in this chapter on page 457 are your Healthy People 2020 objectives. And they're related to immunization and infectious diseases, because that's what this chapter is. Okay. So for example, reduce, eliminate, or maintain elimination of cases of vaccine preventable diseases. Okay, and we'll talk about that in a little bit, what the vaccine preventable diseases are. Those are all your childhood immunizations. Transmission of communicable diseases. I'm not going to go through the environmental, what am I trying to think of? Epidemiological triangle. But we talk about transmission. Transmission of communicable diseases is direct related to the agent, the host, and the environment, right? That's how things are. The agent infects the host, and then whatever is going on in the environment affects the severity of the disease transmission, right? So we're not, let's see, it goes through, we've already gone through this, what the agent is, bacteria, fungi, parasites, we've gone through all that. Goes through the host, which is us, right? Do we have natural immunity, acquired immunity? Do we have active immunization, passive immunization? That's how we're going to react to it. How healthy are we? Okay. And then we know that the environment refers to the physical, biological, social, cultural factors that are external. Okay. The one thing we do need to know is different modes of transmission of infectious diseases. And here's your 4 that we need to know, page 459. Vertical transmission, horizontal, common, and vectors. Okay. So you can go through and review those. Okay. How do we surveil communicable diseases? Well, we first start by gathering the who, when, where, and what. So gather as much information as possible. And then when we have all that information, then we can start to answer, excuse me, answer the question of why. Right? So a good surveillance system follows the nursing process, right? It collects data, it organizes it, it analyzes it. Okay. And then when all that's done, we can release the information promptly to the people who need to know about it so that they can effectively plan, implement, and evaluate. Okay. Infectious disease surveillance incorporates and analyzes data from a variety of sources. Okay, and here's you don't need to memorize this, but here's what the 10 sources are. and here's our this is our second question. This is our second attestation question. What are the 4 emerging infectious diseases? Okay, the first is Ebola. Okay, if you want to read about each of these, feel free to read about each of these. I just want you to know what the 4 are. Okay. Second is HIV. Third is West Nile. I should be highlighting these. Ebola, West Nile. It's actually on one of your slides in your PowerPoint. I have them highlighted here. Ebola, HIV, and influenza. Influenza is the other one. So we get 4: West Nile, influenza, HIV, and Ebola. That's what I want you to know. What are the 4 emerging? And when they say emerging, they talk about over the last 10 years. Okay, this isn't like a year ago or 6 months ago. Okay. Okay, on page 463, this starts, I have highlighted this whole section because I'd like for you to read it, all the way down to the box of levels of prevention. This is a very, I know we should know this already, but this is an excellent summary of primary, secondary, and tertiary. Okay, it starts with, as we discussed in previous chapters, and then it goes through the basics of primary, secondary, and tertiary again. Okay, so if you still don't think you have this concept of primary, secondary, and tertiary down, read through this section. Okay, please. Okay, and then read the section first and then go to the box. And I'm offering, if anybody after reading this section in the box still is confused about these 3 different levels, I want you to contact me and we will get together on a Zoom. And we're going to go through it. Okay. There is a Kahoots that I sent a couple of weeks ago that is specifically related to levels of prevention. I would also encourage you to go back and watch that. I know some students that I've reviewed exam with have already reviewed that. And the ones that haven't, I have suggested that they do. Okay. And then the other part of this chapter that's important is vaccine preventable diseases. I want you to remember this as a fact, this first sentence. Vaccines are one of the most effective methods of preventing and controlling communicable diseases. Okay. Diseases such as polio, diphtheria, pertussis, measles, which previously were epidemic proportions, are now controlled by childhood immunizations. And there's federal legislation. It's called No Shots, No School. Okay, that kids aren't supposed to be in school that do not have updated immunizations. However, they can have exemptions, right? You can have a personal exemption for whatever reason. Parents don't want the child immunized, whatever it is. They can do a personal exemption. You could have a medical exemption where a physician writes a note and says, so-and-so is allergic, or whatever the reason is, allergic to the contents of the vaccination, can't have the vaccination. And then you have a religious exemption, which parents can state for religious reasons or whatever reasons they're not being immunized. Okay, what can we do as nurses? What did I do for 20 years as a nurse? All I could do with parents who didn't want to immunize, which was their absolute right not to, was just try and educate them on how important vaccines can be, and then what the plan was if there was one of these diseases or one of these outbreaks that we had. It's kind of common in the winter in the schools to have pertussis outbreaks. So who were the parents that were called first? The kids who were not immunized for pertussis. And I would tell them, I'm recommending that you keep your kids home until this pertussis is under control, because if your kid gets pertussis and they're not vaccinated, they could get very, very sick. So that's the only way I could deal with it, right? If they weren't going to get it. The other thing I want you to remember is that there are potentially vulnerable populations, vulnerable kids that aren't vaccinated, okay, that need to be vaccinated, okay? And so they're right here. Inner city kids from minority and ethnic groups are particularly at risk for incomplete immunizations. Okay, children from religious communities whose beliefs prohibit immunizations. We just talked about that. It's a religious exemption. And parents who have philosophical objections. Okay, so that's that personal exemption. And we need to be mindful of who's not immunized. Okay, not to be punitive, but to be educated, to do education. Okay. I think that might have been it. They went through different here. Vector-borne diseases, right? What are vectors? Right? Mosquitoes, ticks, right? And it talks about the Zika virus and Rocky Mountain spotted fever and rabies, parasitic diseases. Okay. We don't need to know all the specifics, just the categories. Travelers, people traveling in and out of countries. Right? Potentially a big deal. Right? What are we starting now? We're starting what? Monkeypox? Already heard about that?
Oh my God, I saw that on the news the other day.
Oh my gosh, monkeypox.
Like, what is
Yeah.
this?
So we've got another another communicable disease that's spreading in the last week or so. Okay. And it's starting to hop country to country now. So anyway, we have foodborne and waterborne diseases, right? What if you're cooking in dirty water? Eating food from street vendors that may not be doing appropriate food prep, right? Lots of different kinds of infectious diseases. Okay, so that's it for that chapter. I did want to identify the 4 emerging over the last 10 years. So we got those. Okay. And then the last chapter is looking in particular at HIV, hepatitis, TB, and sexually transmitted diseases. Okay. I let my last group do this on their own because I wanted to give them a little bit of time before their PEDS test to do whatever they need to do. I'm okay with you guys doing this chapter on your own. What I would say though, is that look at your, this is what you need to cover right here, right? When you're looking at HIV, you need to just be able to describe the natural history of it, right? What kind of education does the client need for just HIV? Okay. And then what are the clinical, so go back into each of these four health issues and just pull out these parts that's in the objectives. Just discuss the clinical signs of HIV, hepatitis, STDs. Who's at risk? Objective 3, who's at risk? Okay, what do we do for these people? What are the nursing actions to prevent the disease and care for people who do? So prevention is obviously primary. And what do we do at a tertiary level for people who have these diseases? And this is broken up into it's broken up to 4 sections. Okay. So I'm going to ask you to go back and go through those four health issues. Okay. Questions. Let's go to our attestation. Let's go to our week 7 attestation. I can't remember. What is the first question? Is it the 4 emerging infectious diseases, or is that the second question?
That's the second.
Abuse.
What's the first one?
Signs of abuse.
Oh, yeah. We just went through that in chapter 27. What are some signs of abuse? Bruising.
Behavior,
Yes. Fractures. Isolation. Yeah, absolutely. What else? Keep going.
It can also look like malnutrition.
verbal abuse,
Yep. Mm-hmm. Then the second question, what are the 4 emerging infectious diseases? Remember them?
Ebola,
Ebola?
HIV,
Yep.
West Nile.
Yep.
Influenza.
Yep. Oh, you guys are good. For this late at night, you guys are good. Does anybody have any questions about, we covered 6 chapters, covered a lot of information. I tried to keep it very succinct. Does anybody have any questions? We're in the home stretch now. So we have covered weeks 6 and 7 today. And then next week there's 8 chapters. And for this Monday, I would suggest that you try and get to a live class next week. But after next week, that's it for content. Okay, so we're down to 1 week left of content. And that's next week. And then that's all of exam 3, because week 9, right? Let me stop sharing. Week 9 is exam 3, right? And then in week 10, we use our class time and I do a HESI review. Okay, so we're coming close. Okay, so next week is it for content. And yeah, week 9 is exam. Week 10, I do a HESI review. And you're also offered to go to all the other classes all week. All the live lectures from all the professors in week 10 are all HESI reviews. So you can go to as many as you want. You have to attend this one because it's your regular class time, but you can go to any or all of the other ones as well. So we'll talk about that as we get closer. But yeah. So when you get your study guide this week, see if you can start checking off things that, you know, we went through, and if you need to go back and kind of re-educate, do some research on certain topics, please do. But like I said at the beginning, let's focus the next couple of days on your med-surg exam. Okay? please. I know you guys are, God, I know you guys are working hard, working so hard. I know you are. Really proud of you, though. Really proud of you. And for those that need to reach out to me to review exam 2 and in some cases exam 1, reach out to me after your med surg exam and let me know when you're available. I'll make it work for you. Okay? I'm looking at Rakia's background, and that's where I want to be right now. Anybody want to be in Rakia's background? Can you see it?
Absolutely.
I want to be there. Take me away. All right, I'll stay on if anybody has any questions. Claudia, I want you to stay on for a minute. Margarita, I want you to stay on for a minute. And then everybody else is excused unless you have questions. Have a good rest of the week and good luck on your med search exam.
Thank you. Good night.
Thank you.
Good night. Good night.
Night.
Good night. Claudia, are you doing okay?
Yes,
Doing
ma'am.
a check-in? Okay.
Yep.
Anything you
I
need?
did. I so missed that on the calendar that I was like,
Go back and would you please go back and answer your question, your attestation questions, because I gave you a 0.
for last week.
Yeah, you didn't answer them.
Oh, I think I just signed in.
Yeah, you did. So go
Okay.
back and answer them and I'll change the 0
Okay.
to a 1, but yeah.
Okay.
And then you're just, what did you do with your discussion? Yeah, just turn it.
I haven't. When you told me I was at work, so
Yeah. So
I'll
just
get that down
get it.
tonight.
Yeah. Okay. Sounds good.
All right.
You doing okay though?
Yeah.
Yeah, you're doing good.
I was mad because I was like, dang, I thought I did a lot better. It wasn't bad, but I
No.
wanted another A.
You're fine. You're
Yeah.
good. You're in good shape.
Yeah. Yeah. Yes,
Okay.
ma'am.
Well, if you
All
want to
right.
go over your exam, just reach out and let me know and we'll get together.
Okay.
You
Okay.
know, get through med search this week and then reach out
I
and we
don't
can go
have
through it.
that. I have mental
Oh.
health.
Do you have an exam?
I dropped this last, so I have this in mental health.
Okay. Okay. Well, give me a couple of days to get through teaching and then maybe towards the end of the week, we can go over your exam too.
Okay.
Okay.
Yes, ma'am.
All right.
Thank
Good
you.
deal. All right.
All right.
Bye. Okay. I'm going to take William out of here because I don't think, William, are you around? Oh, I probably should stop recording.